Hi, my name is Wainberg, Associate Professor of Medicine, Co-Director of GI Oncology, and Director of Early Phase Clinical Development at the UCLA School of Medicine, Los Angeles, California. So one of the main issues that comes up in gastric cancer, certainly that's changed a lot in the last number of years, is which patients should have treatment before surgery, and what if they get a gastrectomy and first before they are seen by a medical oncologist, and how should they be dealt with in the adjuvant setting? So about 40% of the time in the United States, certainly patients with gastric cancer identified via endoscopy without metastatic disease are taken straight to the operating room. So do not undergo any neoadjuvant or perioperative treatment and are taken straight to the operating room. In large part, this is done in community hospitals where the ability to do endoscopic ultrasound is sometimes limited, and advanced tumor boards aren't always commonplace to discuss these cases. The patients are taken to the operating room and undergo a gastrectomy, which is usually, ideally, what's called the D2 gastrectomy, but sometimes the D1 gastrectomy is performed, which has less of a lymph node yield, and then gastric cancer has been shown that surgery does matter, and a D2 is preferred. But when a patient comes to the medical oncologist after having had a gastrectomy, one of the big questions in the field is, what do you do now? Do you give them chemotherapy alone? Do you give them chemoradiation? Do you do observation, or do you do immunotherapy? And those are the questions that our field is facing. The first variable to look at is what's the stage, of course. What's the pathological stage? The majority of patients with gastric cancer will have at least a T3N1 disease, which means that tumor is invaded into the muscularis and that indeed at least a number of lymph nodes have been involved. The typical approach has been to start with chemotherapy, and this is based on primarily Asian literature suggesting adjuvant chemotherapy for 6 months, such as Capox or FOLFOX substituting is acceptable as well, has been shown to improve survival over observation. And so a lot of that literature is based on Asian studies, but it's completely relevant in the United States as well for patients who have had a gastrectomy. Historically, we did give a lot of adjuvant chemoradiation based on what's called the intergroup study 0116, which is an older study from about 20 years ago that showed improvement in survival and chemoradiation after surgery versus observation, who received chemotherapy sandwiched, essentially chemo first and then radiation, and then chemo again in the back end, but essentially fractionated radiation to about 40 to 50 gray to the gastric bed, and that also improved survival. Now, the challenge with that study is that it's a really, in our field, it's considered a landmark study, but an older study. And by that I mean that more contemporary studies since then, which have addressed the notion of adding radiation post-gastrectomy, have not shown improvements over chemotherapy alone. And those were studies done in Europe, in Asia, and in the United States to some extent, and really didn't show that adding chemoradiation to chemotherapy improves survival, indicating that the majority of these patients do die of systemic disease and less so local recurrence. So as a consequence, there's been a shift in the treatment of patients with gastric cancer after having had a gastrectomy, which now tend to do chemotherapy alone for 6 months with Capox or FOLFOX, which I think is the most appropriate regimen, and not doing radiation. There are certain cases when one could consider radiation with high lymph node positivity, what's called D2 or D3 lymph nodes, or in a situation where N2 or N3 lymph nodes, where there's a number of lymph nodes involved, and in some cases that could be considered. Or alternatively, some oncologists have felt that if one has a D1 gastrectomy, and this is also in the guidelines, which is as I mentioned, a non-ideal gastric cancer surgery, that radiation could possibly make up for an inadequate gastric cancer resection. So there is these sort of schools of thought about chemotherapy alone being sufficient for patients who have had a D2 gastrectomy, which is becoming a little more common, and for a D1 gastrectomy, consideration of chemoradiation be given.